سنتر كبير قوي، احسن السنتر.
ربنا يوفق حضرتك ان شاء الله. دكتور مينا، نبدا نفتح للزملاء. دكتور مينا،
تمام يا دكتور، فتحت الويبينار.
الزملاء الاعزاء بداوا يجوين اهم معانا.
تمام. لما يبقى الناس جاهزه انا ممكن
احنا
اشير
just 2 minutes يا
البرزنتيشن.
فندم.
مفيش مشكله.
لان الزملاء بيجوين معانا. احنا معانا كل زملاء بيبقوا من مصر ومن العديد من الدول العربيه. معانا الزملاء من كل حته، من سوريا، من اليمن، من العراق، من فلسطين، من ليبيا، من الجزائر. يعني معظم الدول العربيه معانا بصراحه يعني. واحنا طبعا
والله انا
بنرحب بيهم كله.
متابع من قبل ما اعرف حضرتك على الفيسبوك، شايف الجروب وشايف النشاط
ربنا يكرمك يا فندم.
الاديوكيشنال، بجد والله حاجه جميله جدا جدا. ربنا
ربنا
يجازيك
يكرم
خير
حضرتك
يعني.
يا فندم. ربنا يكرم حضرتك يا فندم. ربنا ينفعنا بيه بس يا رب، اللهم امين.
يا رب يا رب.
ربنا يبارك في حضرتك. just 1 minute لان الزملاء بيجوين،
لا
العدد
مفيش
بيزيد.
مشكله.
فعلى اساس ان هم يعني ما حدش يلوز اي كلمه من التوك يعني. واحنا انا شايف
يعني
كل
كمان
الاخوه والاساتذه والزملاء الافاضل السبيكرز بيحاولوا مور اور ليس ان هم يعني بصراحه، بالذات يعني اخواتنا في انجلترا، بيحاولوا يخلوا التوك والبرزنتيشن مور براكتيكال. يعني مش اكاديميك اكتر منه، ما هو اكاديميك مع براكتيكال، بحيث ان هو يعني كل الزملاء يستفيدوا منه في التيبس والتراكس بتاع الاوبريشنز دي. مهمه قوي.
طبعا. انا مش هيبقى في كلام عن الايفيدنس كتير، الحاجات دي كلها موجوده اونلاين. احنا
بالظبط،
خلينا
موجوده
اكتر
اونلاين
على
بالظبط.
البرنسبلز والبلاننج والسيرجيكال تيبس ان شاء الله.
والله يا دكتور تامر، انا بفكر اذا ربنا سبحانه وتعالى يسر لنا ان احنا بعد ما نخلص الكورس مع الزملاء الافاضل الاوفرسيز، ان احنا نعمل كورس على السيرجيكال تكنيكس تيبس اند تريكس. وممكن نجيب فيه لايف بقى، لايف ورك شوبس ولايف سيرجريز، ويعني العديد من الاساتذه يتكلموا على التيبس والتريكس في العمليات، بحيث يبقى احنا كده خدنا الجزء النظري، وفي نفس الوقت ان احنا شغالين في الجزء البراكتيكال، بحيث يبقى في اوضه العمليات كله يعني لما يبقى فيسد باي بروبلم يبقى عارف يتصرف معاها ازاي. فنقل الخبرات دي مهمه قوي يا فندم.
طبعا طبعا، ومش بس مهمه كمان للناس اللي هم مثلا نواب او كده. لا، انا لما بشوف حتى ني سيرجن تاني بيشتغل، باخد منه تيبس اند تريكس، حتى لو حاجه صغيره دي مفيده كمان، اللي هو كمان بيوبريت، مفيده لاي
بالظبط،
حد.
مفيده لنا
اي
كلنا
حد
بالظبط.
اي حد بيشتغل في الجراحه عارف انه هيفضل يتعلم يعني لغايه ما يبطل
كلنا
شغل.
كلنا يا فندم.
طبعا
كلنا،
طبعا
ما حدش كبير على علم ابدا.
طبعا.
ربنا يدي حضرتك الصحه يا فندم. احنا ريدي يا فندم، لو تسمح لي ابدا اقدم حضرتك يا فندم.
اتفضل اتفضل.
بسم الله الرحمن الرحيم. احنا موعدنا اليوم مع يعني محاضر متميز جدا في الاوفرسيز ايجيبشن اوفرسيز اونلاين كورس، دكتور تامر سويد. دكتور تامر سويد كونسلتنت في اورثوبيديك سيرجري يونيفرسيتي هوسبيتال بيرمنغهام. دكتور تامر يعني يسعدنا ان هو يشرفنا وان هو ينقل لنا خبرته في الني سيرجري. دكتور تامر بيه هيتكلم النهارده على الاوستيوتوميز اراوند ذا ني، هاي تيبيال اوستيوتوميز، distal femoral osteotomies, indications, surgical technique and outcome. دكتور تامر بيه، احنا شرف لنا تواجد حضرتك معانا، وبنرحب بحضرتك ترحيب شديد يا فندم.
ربنا يخليك يا رب. انا احب اشكر حضرتك جدا 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 على الدعوه الكريمه وعلى التعامل الجميل والراقي، وانا بتشرف ان انا اكون موجود معاكم النهارده. وبصحيح انا ببقى مبسوط اي حاجه ليها علاقه بمصر، سواء اونلاين او حتى فيس تو فيس، ببقى مبسوط جدا يعني. ابدا اشير برزنتيشن.
اتفضل يا دكتور تامر بيه.
بس بحاول اختار انهي. باينه دلوقتي؟
باينه يا فندم سيادة. فول سكرين بقى
تمام.
يا فندم.
بسم
تمام.
الله الرحمن الرحيم. انا تامر سويد، كونسلتنت ني سيرجن، يونيفرسيتي هوسبيتال بيرمنغهام. يونيفرسيتي هوسبيتال بيرمنغهام هي واحده من اكبر التراست في يو كي. هي 4 هوسبيتالز: كوين اليزابيث هوسبيتال، دي التروما سنتر، وفي هارتلاندز هوسبيتال، وجود هوب هوسبيتال، وسولي هول هوسبيتال. أنا برضو one of the founders of the Birmingham knee school with my colleague, Mr. Tarek Boutafnouche, and we had our first meeting yesterday. So today I'm going to talk about high tibial osteotomy and distal femoral osteotomy basics. For high tibial osteotomy, I will talk about indications, deformity analysis, pre-op planning, some tips on surgical technique and outcome. So what are the indications of isolated medial indications of high tibial osteotomy? The indication is medial compartment osteoarthritis. And when you see such patient in clinic, you're thinking of your options, which would be a high tibial osteotomy, unicompartmental knee replacement, or a total knee replacement. So what is the indication for high tibial osteotomy? So the ideal patient for a high tibial osteotomy would be a patient age 40 to 65, a high demand patient, normal patellofemoral and lateral joints, malalignment less than 15 degrees, with a metaphyseal varus deformity of the tibia or extra-articular deformity, BMI less than 30, full range of movement, and non-smoker. This consensus is about the painful varus knee from ESCA. It's a great consensus. I had the pleasure to contribute to this consensus as a knee fellow. This consensus have got everything you need to know about high tibial osteotomy. You can access the consensus. It's for free. The PDF is available online if you scan this barcode. So from this consensus, we've talked about the ideal patient, but what's the evidence or the outcome depending on the gender, for example? Influence of gender is not very clear, but generally young male patients, they do better with an osteotomy. Aged, there is no cut off line, but generally, again, it's about the physiological age, not the chronological age. So for example, if a patient is 65, but he's very active runner, you might consider him for an osteotomy. Degree of osteoarthritis, bone on bone is not a contraindication, but we know from the literature that severe arthritis, they don't do as well as mild or moderate osteoarthritis. BMI more than 30, they have got higher complication rates. Again, it's not absolute contraindication. For smoking, we know from literature that there is increased risk of complications like infection and delayed union. Heavy smoker, definitely no. I'm not doing an osteotomy on a heavy smoker, but generally, if you can get someone to quit smoking for 3 weeks before and after surgery, that would be acceptable. So now we've got a patient who's got medial compartment osteoarthritis, potentially a candidate for a high tibial osteotomy. What do we need to do? First, we need to do a radiological evaluation. Radiological evaluation, we've got 3 steps. We need to assess the severity of the deformity and then do a deformity analysis, meaning find out where is the deformity coming from, and then think about our intended correction and our hinge point. So the severity of the deformity, this needs to be done on long leg views. This has to be definitely standing views with the patella centered. And why we should have the patella centered, I'll show you an example. So on this view on the left, this is a long leg view of one of my patients post-surgery, high tibial osteotomy. And on the right side, this is just a close-up to make it a bit clearer. As you can see here, the mechanical axis looks like it is passing through the medial compartment, which is disappointing post-op. However, if you look closely, the patella is not centered, and the overlap between the proximal fibula and the proximal tibia is more than 1/3. So this is not an adequate long leg view. This is rotated. And then repeating the long leg view for the same patient, as you can see here now, the mechanical axis is passing through the lateral compartment, just around the tip of the lateral tibial eminence, which was the intended correction. To assess the severity of the deformity, you need to draw the mechanical axis, which is a line from the center of the femoral head down to the center of the ankle joint. And we call this line a Michaelis line. And the way to assess the severity or how to calculate this is by measuring the distance from the most medial part of the tibial plateau and then divide this distance by the width of the whole proximal tibia. And then you get a percentage, and in this example, it's 16%. It's important to unify the terms. So if I'm saying 16%, it means 16% from the medial side. If I'm saying the Micklitz line or the mechanical axis is 70%, it means that the mechanical axis is passing through the lateral compartment. So always refer from the medial side. So now I've assessed the severity of the deformity. This is a patient with a severe varus deformity. The mechanical axis is passing through the medial compartment. So again, potentially a candidate for osteotomy. Then the next step would be finding out where is the deformity coming from, or do a deformity analysis. And doing the deformity analysis, you need to assess few angles, the MLDFA and the MPTA. And on this diagram, you can see all these angles. I break it down. So the MLDFA, or mechanical lateral distal femoral angle, is the angle between the mechanical axis of the femur, or a line from the center of the femoral head to the center of the knee joint, and then another line tangential to the articular surface of the femur. And the MLDFA is normally 87 degrees plus minus 3 degrees. Next step would be drawing the MPTA, and the MPTA is an angle between the mechanical axis of the tibia and then a tangential line to the articular surface of the proximal tibia. And again, this angle luckily is the same value, so normally this is 87 plus minus 3 degrees. So most of the time in patients with medial compartment osteoarthritis, the abnormality will be in the MPTA. And if that is the case, we know the deformity is from the tibia, then you can go ahead and do a high tibial osteotomy. However, occasionally the deformity will be originating from the femur. In that case, if you do a high tibial osteotomy, you're creating a deformity in a normal bone, and then you end up with an oblique joint line. So if the deformity is coming from the tibia, which is very, very unusual in medial compartment patients, medial compartment osteoarthritis patients, then you should do a distal femoral osteotomy, not a proximal tibial osteotomy. Now we've measured our angles. We know that the deformity is coming from the tibia, and the patient is a good candidate for a high tibial osteotomy. We need to think about our intended correction. So it's variable in literature, and historically it used to be the Fujisawa point, which was 67% Micklitz, or going so far into the lateral compartment, but this has changed for a number of reasons. First, if you do such a big correction, the patient might do well initially, but then because you're overloading the lateral compartment, it starts failing, and then the osteotomy doesn't last for long. Another reason is, with this big correction, if this patient needs a knee replacement in 5 or 10 years, then this knee replacement will be challenging. So now most surgeons go between 55 to 60%. I go 55%, which means my intended or new mechanical axis will be 5% lateral to the neutral mechanical axis. If I'm doing an osteotomy for ligamentous laxity, I would just correct the alignment to neutral. Now we've thought about the correction, and then our hinge point should be around 18 millimeters distal to the joint line, 5 to 10 millimeters from the lateral cortex of the tibia, and this is usually at the level of the tip of the fibular head. However, sometimes if the anatomy is a bit abnormal, if the fibular head is a bit too high, you need to be aware of this, because your osteotomy will be very close to the articular surface, and you might get a type 3 hinge fracture. So make sure your osteotomy is 15 or 18 millimeters distal to the joint line. So now we've got the patient, we've done the deformity analysis, we know it's coming from the tibia, we've thought about the hinge and the correction. Now we need to have a pre-op plan. We've got 2 options, and now actually we've got 3 options. So one option is using one of the softwares for planning, like TraumaCAD. These softwares are very helpful. They are less time consuming, and they are very accurate. The other option would be 3D planning. You can get a CT scan and a 3D model and do all your planning. That's not available everywhere. But what should be available to everyone is plain X-rays. So if you've got the long leg views, you can use the Miniachi technique. So with the Miniature technique, you draw the mechanical axis, which is again a line from the center of the head to the center of the ankle joint. And then your second line would be the intended new mechanical axis. So for example, if I'm aiming to go 55%, my new mechanical axis will be passing through the tip of the lateral tibial eminence. So now we've got two lines, both originating from the center of the femoral head. This is a close-up just to make things a bit clearer. This is the mechanical axis, the original mechanical axis, which is in varus. And then this is the intended new mechanical axis. The second step would be drawing a line from the hinge point. This is the hinge point we've discussed before. Our first line will be going to the new mechanical axis, and then another line going to the old mechanical axis. The angle you get from these two lines is called the alpha angle, and this is the angle of our correction. What you need to do then is recreate this angle to the osteotomy site. So you draw another line from the hinge to your osteotomy site, and then another line with the same angle. So for example, if my alpha angle was 7 degrees, as shown in this example, you need to get the angle between these two lines at the osteotomy site as 7 degrees. Once you've done that, you can measure your osteotomy gap. So here, for example, it's 9.9. Let's say 10 millimeters. And it's very important here, these x-rays are calibrated. So if you look at this ruler on the x-ray, it will tell you what is 1 centimeter on the x-ray compared to reality. So it's very important to readjust your measurements according to the calibration. So we've got now a wedge of 10 millimeters. I know I want to get a 10 millimeter wedge, but there are a few things you need to consider. First, the saw blade thickness. So for example, if I'm going with the saw blade, doing my osteotomy, coming out, I will end up with a gap. And this gap is around 1 millimeter. So what you need to do is to add this 1 millimeter to your correction. So if I'm getting from my pre-op plan a 10 millimeter wedge, I need to add 1 millimeter, so I should be aiming for an 11 millimeter opening wedge. One more thing to consider is the joint line convergence angle, which is the angle between the articular surface of the femur and the articular surface of the tibia. This angle is normally 0 to 2 degrees, so if the joint line convergence angle is normal, you don't need to change anything. However, if this angle is excessive, like for example, as you can see in this diagram, this is a very big joint line convergence angle. If you do your planned correction without any change, then you will end up with an overcorrection. So this is a very nice article from Matthew Olivier, who's one of the big figures in the world of osteotomy, and this paper gives you a formula on how to deal with this. So the formula is joint line convergence angle minus 2 divided by 2. For example, if my joint line convergence angle is 7 degrees, which is too much, then I take 2 out of 7, that should be 5, and then divide that by 2, and that's equal to 2.5 degrees, which means I will take 2.5 degrees from the correction, intended correction. So if my alpha angle, for example, was 10, I would make a correction of 7.5, not 10, to avoid the overcorrection. Surgical technique, I will just talk about a few tips. So it's a biplanar osteotomy. A biplanar osteotomy, it is more stable in case you get a hinge fracture, and it gives you more surface area for healing. The approach is a direct medial approach. Personally, I don't do any minimally invasive. I think with an osteotomy, you're putting a saw blade, you're worried about the vessel. I don't think there is any reason or any benefit from doing small incisions. Do a proper incision to have a proper visualization. Then the second step would be MCL release. MCL release is a very important step in this operation. You can release the MCL subperiosteally, or some osteotomy surgeons just cut completely the MCL transversely. I don't do that, but whatever you do, you need to release the MCL, because if you don't release the MCL and start opening, the osteotomy, because the MCL insertion is distal to this osteotomy, then what you end up is overloading the medial compartment. Another important point is having a fixed starting point for your osteotomy. So in my pre-op planning, I should know on the X-ray where is my starting point for the osteotomy, and replicate this or match this intraoperatively. So what I do is on the X-ray, I make sure my osteotomy is around 40 millimeters from the joint line, and then intraoperatively, I match this. What I do is get a K-wire 40 millimeters measured from the joint line and then mark my osteotomy. It doesn't have to be 40 millimeters. It depends on what blade you use, but with the Tomofix blade, usually a 40 millimeters works well. But whatever you do, you need to have a fixed point for the osteotomy in the pre-op plan and intraoperatively. Protection of neurovascular structures, so it's really important. You don't want to end up with any vascular injury. You can use a Homan, and when you're putting the sew, the very important thing during this operation, once you've done the MCL release, you release the soft tissue structures posteriorly, subperiosteally, and then you leave your Homan behind your proximal tibia, and this has to be there whenever you're putting the sew. The Homan should be behind the sew. If you can have a radially loosened Homan or retractor, that can be very helpful, but you can still do this operation very safely, but you have to have a Homan. Precision sew, again, that's a bit of a luxury. Precision sew is a sew that oscillates only on the tip. The rest of the sew doesn't move at all, which makes it very precise. It is safer because there is much less movement in the sew blade. If you can have this sew, that can be very helpful. One important thing, the direction of the osteotomy. So this is a cut section from a cadaver, and as you can see here, this is the saw blade. When you start your osteotomy on the anteromedial aspect of the tibia, your saw blade is really heading towards the fibula head and towards the vessels. So once you've started your osteotomy, what you need to do is change the direction by 45 degrees. And then when you're doing the posterior cortex, you change the direction so you're more or less parallel to the vessels, and you should still have the Homan behind the proximal tibia protecting your neurovascular structures. Outcome of high tibial osteotomy, in literature, it's 70 to 75% survivorship in 10 years with improved functional outcome scores. This is a very nice paper from the Finnish registry with more than 3,000 patients, and the survivorship in 10 years was 73%. And the endpoint in this study was having a total knee replacement. Now moving to distal femoral osteotomy, again, it would be very similar in principle. I'll talk about indications. Again, we have to do a deformity analysis and planning, a few surgical tips, and the outcome. Indications, obviously, for a lateral compartment osteoarthritis would be, for distal femoral osteotomy would be isolated lateral compartment osteoarthritis. And you've got two options: either do a lateral opening wedge distal femoral osteotomy or a medial closing wedge distal femoral osteotomy. Medial closing wedge is better for a few reasons. It is more stable because it's a closing wedge, and potentially less pain post-operatively. And the fact is, if you've done this medial approach just few times, you'll find that it is a very straightforward approach. It is much less destructive for the soft tissues. It just, you need to see it once or twice, and then it should be very straightforward. With that approach as well, you avoid any irritation to the iliotibial band, and some patients, because of the opening wedge, you're stretching the ITB and they get some pain related to that. Radiological evaluation will follow exactly the same steps. Severity of the deformity, do a deformity analysis, think of your correction and the hinge point. Severity of the deformity, again, long leg views, weight bearing, definitely, Mikulicz line, mechanical axis, and in lateral compartment osteoarthritis, this will be going through the lateral compartment normally. You draw your angles again. MLDFA, which is normally 87 plus minus 3 degrees, and then MPTA, again 87 plus minus 3 degrees. In lateral compartment osteoarthritis, most of the time, again, the deformity will be in the femur, and then you treat that with a distal femoral osteotomy. However, occasionally the deformity will be in the tibia, and then if that's the case, you should not be doing a distal femoral osteotomy. If you're doing an osteotomy, it should be a tibial osteotomy. One more thing, if your deformity is really severe, and then with your correction, let's say the MLDFA will go high, really high with your intended correction, more than 4 degrees, you should be thinking of having a double level osteotomy. Intended correction, again, I go 45% for lateral osteoarthritis, and for high tibial osteotomy, it was 55 because we're always referring from the medial side. So in lateral compartment osteoarthritis will be 45%, which means my new mechanical axis should be 5% medial to the neutral mechanical axis. Hinge point, it's 10 millimeter from the lateral cortex, just above the flare of the lateral femoral condyle. However, there is some evidence now that distalizing this hinge point into the metaphyseal bone gives you less chance of having a hinge fracture. For planning, it's very similar, but instead of drawing all your lines from the femur, you draw all the lines from the tibia. That's why this is called a reverse Mignacci technique. So this is a long leg view. First line is the current mechanical axis, a line from the center of the ankle joint to the center of the femoral head, and then you draw another line from the center of the ankle joint towards your intended mechanical axis, new mechanical axis. So in this case, my new mechanical axis is just going through the medial tibial eminence. So that's a close-up again for clarity. And now we start drawing the lines from the hinge point. So the first line would be a line from the hinge point to the old mechanical axis, and then another line to the new mechanical axis, very similar to the alpha angle that we use for the high tibial osteotomy. You get this angle, and this is the angle that you need to recreate in your osteotomy. So you copy this angle to the osteotomy site, a line from the hinge point towards the osteotomy, and then another line with exactly the same angle. Once you've drawn these lines, you can measure your osteotomy. So this is the wedge that you're going to remove here, 8.6 or let's say 9 millimeters. Surgical tips, again, it's a biplane osteotomy, and that is even more important in the femur because of it gives you more stability. In case you get a hinge fracture in the distal femur, if your osteotomy is not a biplanar, you might end up with a very unstable fracture, and then it's not going to be a very nice day. So this is very important. Gives you more stability and more surface area for healing. One top tip is using a hinge wire, and the hinge wire is just a simple 2 millimeters K wire passing through the hinge, through your hinge. And what this wire does is protection of your hinge, and it protects your hinge by joining the proximal and distal fragments of the bone, and it also protects your hinge by stopping your saw blade. So here in this example, this is my hinge wire. I've got the proximal K wire, distal K wire. I've taken the wedge already below this wire so I've taken the wedge between these two wires, and then with the hinge in place, I start closing my osteotomy. So this is my osteotomy closed. There is no gap. And if you notice, the wire looks a bit bent, and I think this is a great tip, and there is evidence that in literature that this decreases the risk of hinge fracture. Outcome, it's 60 to 90% survivorship in 10 years with improved functional outcome scores. Thank you. I've got a few case examples. It's up to you. We can go through the cases or have questions.
We have time, Dr. Tamer.
Yeah, I know. Through the cases. Okay, so questions at the end?
Yes, sir.
Okay. I would have loved to have this a bit more interactive, but I know you can't get candidates to ask questions now. So this is an example, 56 years
حضرتك بعد
old.
اذن حضرتك دكتور تامر بيه، لو حبيت ان احنا نبقى انتراكتيف، احنا ممكن ناخد الكويستشنز اللي موجوده دي، وبعدين الزملاء بيعلقوا على كل اكس راي 1 باي 1. فايه راي حضرتك؟
تمام، يعني يكون احسن طبعا.
اوكي طيب we have some questions.
ناخد questions الاول على البرزنتيشن
على البرزنتيشن
تمام، يا ريت، ماشي.
اوكي، وبعد كده حضرتك نبدا ناخد الكيس برزنتيشن كيس باي كيس.
تمام.
اول سؤال دكتور متولي: how do we handle the MCL in medial open wedge high tibial osteotomy? I think دكتور متولي ان الدكتور تامر بيه يعني قالوا باستفاضه في الشرح، مش كده يا فندم؟
You have to do an MCL release. You can't do this osteotomy without an MCL release. لأن the MCL starts in the femoral condyle, goes down 6 centimeters distal to the joint line. So if you do the osteotomy, try to open it up, your MCL will be stopping you opening your wedge. And what you'll be doing is putting pressure on the medial compartment. So you have to do an MCL release. Some osteotomy surgeons just cut it transversely. I feel that's a bit too much, but they don't have problem with this. Personally, what I do is just lift like what you do for a knee replacement. So I lift the whole MCL subperiosteally. When if you do this, strip the MCL subperiosteally, and if you get the Homan deep to the MCL, okay, you probably have done enough release.
Yes, sir. Another question from Dr. Gamal Qasim is Mayaneshi is the standard operation for high tibial osteotomy, or it's directed for specific cases relating to age, sex, and medial condition?
What was that again?
Medical condition.
Sorry, can you repeat the question again?
In Mayaneshi.
In what?
In Mayaneshi.
Okay, yeah.
Is the standard operation for the high tibial osteotomy, or it is directed to specific cases relating to age, sex, weight, and medical condition?
No. So the Miniachi technique is just a technique to have a pre-op plan for a high tibial osteotomy. Any high tibial osteotomy. There are some other ways, okay, but the Miniachi technique is the commonest technique used. You can use softwares like TraumaCAD, but Miniachi, you use it for any high tibial osteotomy. So if you decided that you can do a high tibial osteotomy for a patient, just use the Miniachi technique. I think if he's asking which patient, we can discuss this later, like which patient should get a high tibial osteotomy, which patient should get unicompartmental knee replacement. We can go through this once we've done the case discussions.
Yes, sir. Another question from Dr. Gamal: for high tibial osteotomy, is there a rule for using open wedge versus closed wedge, and which technique is preferred?
So now most osteotomy surgeons use an opening wedge osteotomy, medial opening wedge osteotomy. Personally, I've never done a closing wedge. Now, it's very, very commonly an opening wedge. A number of reasons. So first of all, the union rate for an opening wedge, although you leave a wedge without, you're leaving a gap behind, the union rate is very similar. With the new plates, the locking plates, the new techniques, and the advancements in high tibial osteotomy in the last 2 decades, the results in terms of union are very good. The main reason I wouldn't go and do a lateral closing wedge is the risk of nerve damage. In the literature, this is around 2 to 3%. And the last thing I would like to have with any patient, not only osteotomy patients, is the common peroneal nerve damage. This is a disaster. So if you've got an osteotomy that gives you very similar union rate, it's much easier on the medial side. You've got the locking plates. I personally don't go and do a closing wedge. And most osteotomy surgeons do opening wedge osteotomy.
حضرتك في الاوبن ويدج بتفضل تحط بون جرافت او بون سبستيتيوت يا دكتور تامر، ولا بتليف ات فور هيلينج؟
Literature, there is no difference,
Yes.
almost no difference in outcome. During my fellowship, I had access to bone graft wedges, so I was using them for every single osteotomy. And the advantage is it makes the operation much easier. So if I've planned my osteotomy to be 11 millimeter, okay, what I do is we've got a wedge on the shelf, bone graft, which is 11 millimeter. So it depends on the wedge. I've got everything on shelf, 9, 10, 11. So once I've done my osteotomy, I open the gap, put the wedge, and then becomes very easy. Then it is very stable. I don't need to worry, and I don't need to remeasure again. I just put my plate, and then it's just a matter of getting the screws. Now, in my current job, I don't have bone grafts on the shelf, so I just leave it. In outcome, it doesn't make much difference.
Yes. Another question from Dr. Rashid Hashad. I want to ask, how can I calculate my degree intraoperatively?
Intraoperatively, you can't calculate, you can't measure these angles. So the only calculation is the length of the opening wedge. So if my planning was accurate, if I had long leg views properly centered, and I've measured my wedge, for example, 10 millimeter will give me a 55 microliths, then if you recreate this intraoperatively, this is the best way. You can use other things to double check. You can use a rod, pass it from the femoral head to the center of the ankle joint, a metal rod, and check where is your new mechanical axis. You can use the diathermy cable, okay, because you can see this under X-ray. You can put a diathermy cable from the center of the femoral head to the center of the ankle joint. Occasionally, I do this to make myself feel a bit better, but there is a problem here. These are not weight bearing. These measurements intraoperatively, it's not weight bearing, so it doesn't match what you get post-op with a patient weight bearing. But I would go for my first few osteotomies. I would definitely have an intraoperative check with a metal rod. If you don't have a metal rod, you just get the diathermy cable, put it into the center of the femoral head, pass it, get an X-ray, keep it there. Keep it there in place, and then stretch the diathermy cable to get an X-ray, make sure it's in the center of the ankle joint, and then get an X-ray of the knee, check where is your diathermy cable. If it's passing through or close to the lateral tibial eminence, then your osteotomy is probably okay.
Yes. دكتور متولي بيشكر حضرتك جدا على المحاضرة الجميلة دي يا فندم. دكتور علي, how we do biplane osteotomy?
biplane osteotomy. ممكن نرجع. هو بيسأل على التيبيا ولا الفيمر؟
التيبيا most probably, اللي هي كانت في الأول يا فندم لما حضرتك.
اوكي.
Yes, yes.
High tibial osteotomy, biplanar. So what I do is, it will be difficult to explain this, maybe need some drawing, but anyway, so what I do is I pass my K-wire. Yeah, I've got a case example. So you pass the K-wire first. You can use 2 K-wires heading towards your hinge. Of course, all this done under X-ray with the neurovascular structures protected. And then what you do is you make your osteotomy. This is one plane of your osteotomy, and this goes all the way. Can you see the mouse?
Yes, we can see it.
So this is one part, or the horizontal part of the osteotomy. So this goes all the way from the posterior cortex to around 3/4 of the width of my proximal tibia, and then go from here towards the tibial tuberosity. I'm finding it a bit difficult to explain this without having a cadaver or something. But anyway, you mark the patella tendon. So you need to know where is your patella tendon, and then start here. This will be around 1.5 or 2 centimeters. Start the second limb of your osteotomy from here, and then you should go all the way up. So this is the second limb of your osteotomy.
Yes. Okay, thank you sir. سؤال من أخونا الدكتور إبراهيم مقار من الجزائر بخصوص نزول عظمة الردفة بعد قطع العظم. هل يشكل مشكلة؟ Is it a problem؟ الباتيلا طبعا.
It's not a problem in opening wedge medial osteotomy, you get patella baja, but only a few millimeters. It's not significant. The only time where I think or I would worry about patella baja if the patient has got already patella baja. Okay, and in that case, what I might do is, instead of doing my second plane of the osteotomy, going from distal to proximal, I might, I think that I can go a pen. Give me a second. Yeah, so this is my biplanar osteotomy normally. If the patient has got patella baja, I know with this technique, the patella might go down by a few millimeters, which is generally not a problem. But if the patient has got patella baja already, I think you should worry. And in that case, what you need to do is do a reverse biplane osteotomy. So this will be one osteotomy limb, and the second limb will go distally. And this should avoid having a patella baja.
Dr. Karim Mahdi is asking about post-operative protocol.
Post-operative protocol for high tibial osteotomy, 2 weeks non-weight bearing for me, and then weight bearing as tolerated. But you have to be very careful. It depends on what plate you use. You didn't have a hinge fracture, so if you've done a perfect osteotomy, you're using a Tomofix plate, which is a very, very strong plate, then you can follow this protocol for high tibial osteotomy. Distal femoral osteotomy, a bit different. I keep them in a hinge knee brace for 6 weeks, touch weight bearing, because the risk of failure in distal femoral osteotomy is a bit higher. If you're using a different plate you haven't used before, even if it's an osteotomy plate, you need to be a bit more conservative. I had one of my mentors and bosses, he was using Tomofix, done loads of osteotomies, and he moved to another plate and followed the same protocol, and he started having broken plates. So it depends on what you're using. If you're not sure, keep the patient 6 weeks, touch weight bearing.
Yes. We have a question from Dr. Muhammad. What about rough estimation of 10 degrees deformity equal 10 millimeter distance gap?
That's a very old concept. You shouldn't be doing this now, okay? Because if you do a proper planning, you'll find that this formula doesn't work. And actually, what would be the reason for not doing a preoperative plan? For an osteotomy patient, you need to get long leg views anyway, and you can do what I've just shown on just normal long leg views X-ray. You don't need any fancy software. You don't need anything.
Yes. Dr. Ahmed is asking about, there is a specific age that cannot do high tibial osteotomy?
Again, there's no contraindication. I've done, particularly when I was in fellowship, because I did a fellowship with a very high osteotomy surgeon, so high volume. So he did osteotomies for patients who were 65, sometimes 70, but they were very, very active patients. So physiologically, they were much younger. But one thing to put in mind, it's not a tick box, it's more like a scoring system. So for me, if the ideal patient would be like 45, very active, no arthritis, is not a smoker, etc. But if the patient is 60, yeah, or 65, very active, not smoker, no medical problems, he's got extra-articular deformity, he's not keen to have a knee replacement, which is very common in Egypt, yeah, why not? He can. There's no contraindication. He can have an osteotomy. On the other hand, if you've got a patient who's 50, yeah, but a bit obese, smoker, not very active, then you shouldn't be really thinking of osteotomy. And one important aspect in osteotomy surgery generally, this is not a quick fix. These patients are not like arthroplasty patients. Arthroplasty, particularly unicompartmental knee replacement, 6 weeks, or even with total knee replacement, 6 weeks, you see the patient coming back to clinic, happy, almost recovered, can feel the difference, the improvement. Osteotomy patient, it's not a quick fix. So these patients, I tell them pre-op, see, this operation, you'll take around 9 to 12 months to recover. Okay, so healing of the osteotomy takes around 6 months, sometimes up to 9 months. Feeling the benefit from the operation, it's not after 6 weeks. Some of them feel the difference very early, but generally, particularly if these patients are high demand or a manual worker or a builder, they need to know that they might be off work for, if they do a high demand job, they might be off work for 6 to 9 months.
هو الكلام كله بقى دكتور تامر بيه على اليوني كومبارتمنتال فيرسس الهاي تيبيال اوستيوتومي، وكان الكلام كله ان الهاي تيبيال اوستيوتومي it doesn't attack the pathology بعكس اليوني كومبارتمنتال. فهو كان دايما الكونتروفيرسي ما بين هل اعمل يوني كومبارتمنتال ولا الهاي تيبيال اوستيوتومي، هو ده اللي كان عليه الديبيت دايما يا فندم.
تمام. في اوفرلاب ما بين الانديكيشنز، بس مفيش الاوستيوتومي doesn't replace uni compartmental replacement ولا العكس صحيح. في patients indicated لده، في patient indicated لده. This is very, very different from an arthroplasty surgery. A patient who gets a high tibial osteotomy, and what is more important is the outcome at the end. Yeah, it's not attacking the pathology, or it doesn't matter. This patient is coming with pain and he wants pain relief and good function. So you can achieve pain relief with a good function with a high tibial osteotomy or a unicompartmental knee replacement on the short term. But if I'm giving a patient who is 45 a unicompartmental knee replacement, what will happen in the next 20 years? He'll be coming back. So generally, arthroplasty in particularly male patients younger than 55, they don't do very well. Okay, they are less happy. There is less satisfaction. So you're giving the patient an operation. If you're giving this operation to a young patient, let's say 45, unicompartmental knee replacement, he'll be happy after 6 weeks, but then higher chance of having less satisfaction because they're active, the expectations are much higher. And then this patient who's 45 will be coming back maybe when he's 55 or 60 with a loose unicompartmental knee replacement, and then you're thinking about a revision and potentially a second revision. However, if you give this patient who's 45 a high tibial osteotomy, gets a good outcome, which is pain relief, it doesn't matter if you attack the pathology or not, pain relief, good function, and then we know survivorship of the high tibial osteotomy is around 70-80% in 10 years, so 45, and then he gets a knee replacement at 55 or a partial knee replacement at 55, that's a much better outcome. And it's a discussion. So someone who's 55, he is borderline. Okay, someone who's got moderate arthritis, that's not bone in bone. These patients are not indicated for arthroplasty anyway, so arthroplasty for me is excluded. Your conservative treatment or a high tibial osteotomy. Or a patient who's very young, then I would really think of osteotomy more than an arthroplasty. And one more thing is an extra-articular deformity. If the patient does not have an extra-articular deformity, then like an normal MPTA, normal ML-DFA, then these patients with an osteotomy, they don't do very well. Okay, so it's not like right is osteotomy, left is arthroplasty. No, it's a number of things. So very young age, I would be inclined to high tibial osteotomy. Older age, 55 is borderline. You can think of both. 60, 65, I'm definitely thinking arthroplasty.
واحنا احنا معانا العديد والعديد من الاسئله من الزملاء الاعزاء نظرا لاهميه الموضوع يا دكتور تامر.
تمام، كويس، الاسئله جميله.
هو اسمح لي قبل ما نكمل اسئله الزملاء سؤال مني، هل حضرتك بتحب احيانا تعمل هاي تيبيال اوستيوتومي بروفيلاكتيك؟ يعني بيجي لنا كتير قوي يانج ادلتس حوالي 18 و19 سنه ما عندهمش جينوفارم وعايزين يعملوا هاي تيبيال اوستيوتومي، لما بيقروا خايفين ان هم يجي لهم ميديال كومبارتمنتال اوستيوارثرايتس في الاولد ايج، هل بتعملوا بروفيلاكتيك؟ هيز complaining of nothing.
I would avoid doing prophylactic surgery. Always, that's a general rule for me. If the patient is asymptomatic, I would avoid doing any operation, because these operations, they come with a risk. Okay, just the risk of anesthetic, risk of infection, malunion, non-union. You can't. And my quote, or I've learned it from a wise man: you can't make an asymptomatic patient happier. Doesn't matter what you do, he can't be happier. He will not. If it works, it's fine. If it doesn't, he'll be very, very unhappy.
Yeah.
So I don't operate on asymptomatic patients.
Another question from Dr. Mustafa. He's asking about what about osteotomy below the tibial tuberosity?
I've never done that or seen that.
Another question from Dr. Ibrahim Mukar. When we get a painful patella baja after high tibial osteotomy, and do you put graft after high tibial osteotomy? احنا already discussed الموضوع ده.
A graft low, as I said, the outcome is very similar in literature. If you've got a graft, it can make your operation easy. But what I wouldn't do is go and take a graft from the iliac crest. Okay, if you've got an allograft, that's fine. But a graft from the iliac crest, it comes with morbidity. It's very painful. You can have problems, injury to the sensory nerves. I wouldn't go for an iliac crest graft unless there is a good reason.
Yes.
Non-union,
ممكن
for
تاخد bone
example.
substitute يا دكتور تامر بيه احيانا.
Bone substitute, never. Okay. And when I started in Birmingham, I didn't have a bone graft, and I was offered a bone substitute by a rep. Okay, and it's a nice wedge, and I thought maybe try it. And it was during the day when I was doing the osteotomy. So what I did is quickly look at the literature in Google Scholar and Med line, and then the only thing I found was a couple of papers showing higher non-union rate. So I've stayed away from it.
Yeah. Another question from Dr. Ibrahim. You can simulate the mechanical axis pre-operatively?
Which mechanical axis? Well, I don't know, what does he mean? Simulate the mechanical axis? We draw the mechanical axis pre-operatively. Pre-operative planning, but draw the mechanical axis from the center of the femoral head to the center of the ankle, and then draw the new mechanical axis, which I'm aiming for, which would be from the center of the femoral head going down 55% in the proximal tibia, or usually it's around the slope of the lateral tibial eminence.
Dr. Rashid is asking about, did you prefer arthroscopy before high tibial osteotomy?
I don't do arthroscopy before high tibial osteotomy. If he means do an arthroscopy as like a first stage, I don't do this. I get an MRI for all these patients to make sure they don't have arthritis in the lateral or the patellofemoral compartments. Yes, potentially you can do an arthroscopy and then think about the osteotomy, but I don't want, this is a big operation, yeah, and I can't call a patient, get him ready for a big operation, 9 months recovery, and then I put the scope in, and then there is some arthritis in the lateral compartment. Okay, I'm coming out. I think that's not fair, yeah. So I get an MRI for everyone, make sure there is no arthritis in the lateral compartment or the patellofemoral compartment. The only time where I would do an arthroscopy with my osteotomy if the patient has got mechanical symptoms. So if the MRI scan has shown like a big meniscal tear or a fragment flipped under the MCL, then I might go in, just quickly trim the medial meniscus and carry on with the osteotomy, but I don't do it routinely.
Another question from Dr. Salah. In case you have recurvatum and planning to do osteotomy, what's your advice during surgery?
Recurvatum, you need to do a different type of osteotomy. It will be a slope changing osteotomy. And I'll show him an example of that. I've got one in the cases I'm presenting.
Yes. Dr. Mahmoud, how can I preserve the tibial slope?
Very good question. I was expecting that question. Let's go back. I just need to make some drawing to do this. Okay. So tibial slope. So this is like a transverse section in the proximal tibia. Okay, and this is like a lateral view. Okay, I'll just give an example to make this a bit simple, because I struggled myself when I started doing this. I couldn't figure it out why the slope will change. So let's say this is a lateral view, okay, of a knee, and then let's say we're doing an osteotomy, anteroposterior osteotomy, opening wedge. So this will change or increase the slope of this is a slope changing osteotomy. Okay, if we're doing a medial opening wedge osteotomy, we would think that should not change the slope. However, the tibia is not rectangular. If you're doing an osteotomy, if this is the medial side, yeah, if we do an opening wedge osteotomy from medial to lateral, then that should not change anything in our slope. However, the proximal tibia is triangular, and our osteotomy is starting from the anteromedial tibia and heading towards the fibula head. Yeah, so this will be my saw blade. So my osteotomy actually is in an oblique plane. Although I plan everything on X-ray, medial to lateral, when I'm doing my osteotomy, I'm going anteromedial to posterolateral. So if I end up with a gap that is rectangular, I will definitely increase my osteotomy because it's an oblique. My osteotomy plane is oblique. So to avoid changing or increasing the slope, your gap should be trapezoidal. So if I've planned 10 millimeters here at the back, anteriorly, it should be 7 or 6 millimeters. So my gap on the lateral view should look something like this. So this is how to change. So how much difference? It's just a rough estimate. There is no calculation for this.
Yes. دكتور جمال قاسم بيشكر حضرتك على المحاضرة الجميلة
ربنا يخليه يا رب.
ثانك يو دكتور جمال على البيرث داي ويشز. النهارده عيد ميلادي، فيا متشكرين على
كل
البيرث
سنة
داي.
وحضرتك طيب،
حضرتك صح
وربنا
سلام يا فندم.
يبارك لك ويديك الصحة يا رب.
ربنا يبارك في سيادتك يا استاذ. دكتور أسامة, when do we when would you do overcorrection for deformity and how many degrees?
Overcorrection زي ما قلت في ال presentation, the previous principle was Fujisawa point. Fujisawa have got a very popular paper, and he aimed to overcorrect for all high tibial osteotomies to 67.5 degrees. I think it was after the more recent paper we were talking about 60 or 65, but the actual Fujisawa point is 67%, and this is so far lateral overcorrecting. And you would see the X-rays. I've seen this paper. It's a very nice paper with a very good outcome, by the way. Really overcorrection, and you can see like a very oblique joint line. I think this has faded over the years because of the arthroplasty, and we know these patients will get an arthroplasty. So now you don't do any overcorrection. You're aiming 55%, 60 maximum. I wouldn't go anything more than that. And this means 5% or 10% lateral to the neutral mechanical axis. So I never go 65. And I don't think most osteotomy surgeons do that now.
Yes sir. دكتور علي المهدي بيشكر حضرتك شكر جزيل على المحاضرة الجميلة دي يا فندم.
العفو علي.
دكتور لؤي هو بيسأل على برضو using bone graft to fill the gap، واعتقد حضرتك جاوبت السؤال ده يا فندم.
It just makes the surgery easier, but you don't need to use any bone graft.
دكتور إبراهيم مقارلي, another question. In high tibial osteotomy, you open the osteotomy posterior more than anterior or the same distance?
Posterior, definitely more. So if I've planned my osteotomy 10 millimeters on the X-ray, I'll be opening my osteotomy posteriorly 10 millimeters. Anteriorly, it will be around 7 or 6. It has to be a trapezoidal gap to avoid increasing the posterior slope.
Yes. Dr. Walid is asking, we can correct the deformity by Elizarov frame and the corticotomy distal to tibial tubercle with slide translation and with post-operative correction. Is it better than internal fixation? يعني I think إن إحنا عندنا many options للcorrection. يعني لو الدكتور جمال حسني موجود كان.
طبعا there are so many options. I don't do frames. I don't have experience in frames. انا عارف في مصر في عمالقة الفريمز، بس اعتقد الكوركشن بالفريمز هيبقى اكتر للحاجات اللي هي very big corrections. personally او اعتقد اغلب البيشنتس هيفضلوا يبقى فيش حاجة من بره.
Yes. دكتور زياد أخونا العزيز, he's asking, can we correct posterior tibial sloping for patients with deficient ACL at the same time of high tibial osteotomy for medial compartment osteoarthritis?
You can within limits. So if you've got an increased proximal tibial slope, you can play a little bit with the slope. But if you've got a massively or excessive posterior tibial slope, you really need to do a slope changing osteotomy. If the patient has got instability, you're aiming more for ACL and stability. The other option to do a biplanar osteotomy, it becomes a bit complex. If a patient has got medial compartment osteoarthritis, and increased tibial slopes, you want to do one osteotomy to correct two planes. Ideally, if you want to do this with one osteotomy, you need to have a 3D planning. So we've got these, I'll show an example. We've got these companies here. You get a CT of the whole limb, you get a 3D model, and then plan your osteotomy, play with the osteotomy, get the correction on the coronal plane, correction on the sagittal plane, and it will tell you how the wedge should look like, print a 3D jig, and then you just pass and do the osteotomy. But planning this, you can fiddle it a little bit and change the slope, but you can't do it too much.
Yes, but ACL deficiency, Dr. Tamer B, is not a contraindication. يعني حضرتك عارف ان ال ACL deficiency is هو كان absolute contraindication دلوقتي relative contraindication لليوني compartmental. هم فتحوا المجال شويه. But في الهاي tibial osteotomy, in high tibial osteotomy, it's not a contraindication.
في الهاي tibial osteotomy it's not a contraindication، لان انا الهاي tibial osteotomy انا بعملها للبيشنت عنده medial compartment osteoarthritis.
Yes.
لو هو عنده مشكلتين، عنده instability وعنده pain من الارثرايتس، كل مشكله ليها علاج. لكن انا لو البيشنت جاي لي ما عندوش ACL وعنده medial compartment osteoarthritis بس ما عندوش instability، خلاص هو مش symptomatic من ACL او ignore the ACL, do the medial opening wedge osteotomy. If he's got instability and medial pain, then that's another issue. You need to do an osteotomy and an ACL reconstruction, 2-stage or single stage.
Yes. Another question.
For uni compartmental knee replacement, again, it depends on what uni compartmental replacement you're using. So for a fixed bearing, uni compartmental knee replacement, a fixed bearing means the plastic or the polyethylene is fixed to the tibial tray. If the patient has got a deficient ACL but no instability, you can do the uni compartmental knee replacement. You don't need to worry about the ACL. But that's for fixed bearing. If the patient has got instability, medial pain, then you need to do both. For Oxford knee, which is a mobile bearing, meaning the polyethylene is rotating on the tibial tray, you have to have an intact ACL. Otherwise, you get instability, the poly is not fixed, it will flip and dislocate.
Yes. Another question from Dr. Ibrahim. When you prefer the tibial lateral closing wedge?
I don't do tibial lateral closing wedge at all. If it's medial compartment osteoarthritis, I will always do a medial opening wedge.
Yes. Yes. Another question from Dr. عبد الله. وطبعا الاسئله كتيره لان الموضوع يعني very interesting وحضرتك فعلا مركز فيها دكتور تامر بيه على
لا انا مبسوط جدا بالاسئله احسن
هو الدسكشن هو اللي بيثري فعلا، هو اللي بيثري قيمه البرزنتيشن فعلا، وبيبين قد ايه البرزنتيشن دي ممتاز.
انا متاكد ان 50 او 70% من الناس عارفه الكلام اللي انا قلته. احنا اهم خلينا في الدسكشن طبعا.
ربنا يكرمك يا فندم. Another question من دكتور عبد الله. Do you do knee arthroscopy for all patients? I think ان حضرتك already
No,
جاوبت.
I don't. Only if the patient's got mechanical symptoms.
Yes. Dr. Ibrahim, thank you for birthday wishes, Dr. Ibrahim B. Another question from Dr. Ibrahim برضو من الجزائر. When you authorize walking after the operation?
So for high tibial osteotomy, non-weight bearing for 2 weeks, just to give them some time for wound healing, etc., and then weight bearing as tolerated. If I didn't have a hinge fracture, my osteotomy was fine, weight bearing as tolerated after 2 weeks, with a Tomofix plate. Important what you use.
Yes.
So for the Poodle plate, for example, which I've used before,
Yes.
I would keep them non-weight bearing.
Yes. Do you prefer Poodle plate or another type of plate, sir?
Tomofix for me is the standard plate.
Yeah.
It's very strong. It is very well tested, and the outcome in literature is very good.
Yes.
One thing or one problem, which is common, I don't think anyone asked this question, but it's very important. These patients, many of them, around 50%, sometimes more, after the operation, after the osteotomy healing, they have pain, medial-sided knee pain, related to the plate. And in 50% of the patients, you need to remove this plate. And I think this is important for the patients to know. You might have a second operation to remove the plate, and it's important to know you might have pain coming from outside the joint, and it's related to the plate. And sometimes the patient gets pain relief in the same day. You remove the plate, pain is gone. Why? How it happens? We don't know. Okay. I'm about to publish or trying to publish a paper about plate removal after high tibial osteotomy, but the one explanation is that these plates are very stiff, Tomofix plates. They are very stiff, locking plates, so the whole construct is very stiff, and there is a mismatch between the stiffness of the construct or the plate and the bone, modulus of the elasticity of the bone and the modulus of elasticity of the plate. That's potentially a reason why they get this pain.
Another question from Dr. Ibrahim. When you have ACL rupture, you prefer to do both operations in the same time?
I prefer to do 2-stage operations. It's nice to do complex surgery. I don't like to do heroic surgery, at least for now. Let's go keep it simple.
Yes.
But it's definitely an option if you've got the skills and around you and you're very comfortable. Yeah, go ahead.
Yes. The last question عشان ناخد الكيس presentation من الدكتور ضياء. After high tibial osteotomy, do you need to remove the implant if it is asymptomatic?
No. Sometimes they might need the implant removed if they need a knee replacement in 5 years or 10 years. But if the patient is happy, why give him another operation with some risks? Although the risk is minimal. But I've seen actually patients getting infection when they came back for removing the plate. So they had no infection, healed osteotomy, happy, come back, remove the plate, they get infection. So that's not very pleasant.
We have finished questions دكتور تامر. وطبعا كثرة الأسئلة يعني indication لأهمية الموضوع وجمال المحاضرة بصراحة يا فندم.
لا انا بالعكس انا مبسوط جدا بالاسئله، ودي بتخلي الموضوع انا بالنسبه لي لما بقى حاجه انتراكتيف احسن من انا اقعد اتكلم. وحاجه تانية، احنا الاوستيوتوميز ما بتتعملش كتير هنا، حتى نسبيا ما بتتعملش كتير، وفي مصر احنا المفروض عندنا انديكيشنز تكون اكتر بكتير لاسباب كتير. اولا البوبوليشن عندنا اصغر، عندنا ناس كتير بتخاف من الني ريبليسمنت، الني ريبليسمنت اغلى كتير. بس هتبقى المشكله عندنا السموكرز، عندنا السموكينج طبعا prevalence is very very high in young males. بس هي المفروض عمليه جميله جدا و it's almost reinvented in the last 20 years. This, you know, the history was my seniors and professors in Alexandria, they said, yeah, we used to do the dome osteotomy, it used to work very well in the old days, and then when the arthroplasty came, osteotomy disappeared, which happened like all over the world. I think osteotomy was the treatment for arthritis, and then arthroplasty came out, very good results, and then we had only arthroplasty, and then the last 20 years osteotomy came back again with the new techniques, the locking plates. Now osteotomy is more of a scientific and well-calculated operation.
هو قبل ما نشفت للكيس برزنتيشن هو في 2 questions كمان كتبوا دلوقتي يا فندم، فلو تسمح لي ان احنا ناخدهم معانا يا فندم.
طبعا.
First question from Dr. Saif: the risk of non-union after high tibial osteotomy.
Risk of non-union for opening wedge high tibial osteotomy is around 3%, so it's not very common. But to avoid non-union, avoid smokers, okay, and established non-union is very rare. Sometimes you see a delayed union, and then 6 months healing is not great. Many times, if you wait, unless there is a technical error, that's another thing. If the osteotomy, you've done a proper osteotomy, there was no hinge fracture, no displacement, then when you wait, it will heal. If it doesn't, you can think of having a bone graft. But if there was a failure or a broken plate, then you're more thinking of a revision than bone grafting. And of course, what you need to do is just rule out infection. If the patient is a smoker or went back to smoking, ask him to stop smoking, check other medical problems, check your host, just do the workup for any non-union.
Yes. Another question من دكتور علي النصراوي: what about the proximal fibular osteotomy in osteoarthritis of medial compartment of the knee?
I've heard about it. I've never done it. I think this is done mainly in India with some publications, but I think it's low evidence. Okay, but I haven't done it. It's not done in the UK.
Yes, sir. هو last question وختامه مسك من استاذنا العزيز سياده اللواء الدكتور هشام العشري: what about limb length discrepancy?
Limb length discrepancy is not a problem with these patients, because if you think if we've got a straight limb, okay, and then a limb with a varus, yeah, and then you straighten the varus, you should be really getting it like كأن في banana وانت خليتها straight. ممكن patient will gain few millimeters, but it's never a problem really. With small corrections, if you're doing a big correction, that's another story. For example, this is something we haven't mentioned. If a patient has got a severe varus deformity, young, etc., and he is a candidate for a high tibial osteotomy, okay, but this deformity is severe, and with these patients, what you'll commonly see is a mechanical axis passing outside the joint, so the line from the center of the femoral head to the center of the ankle joint is completely outside the joint. These patients, if you do a correction with a high tibial osteotomy, it would be a very big correction. And if you do a very big correction, you'll end up with an oblique joint line, okay? And then you increase the shear forces in the knee, and then the outcome is not very good. So if you've got this severe osteotomy, severe deformity, you probably should be thinking of doing a double level osteotomy. Okay, so, and the way to make this decision is to look at your pre-op plan. So MPTA is normally 87, right? Plus minus 3 degrees, so 87 to 90. So if your post-op or pre-op plan shows that your MPTA is going to be anything more than 94, you should be thinking of doing a double level osteotomy. Okay, so a distal femoral osteotomy and high tibial osteotomy. So 94 is your upper limit. If you think your MPT will be 100 or something, that's going to be a very big correction. Then you should be splitting your correction. If you think you need a 14 degrees correction, make it 7 degrees in the tibia and 7 degrees in the femur. Big operation, big surgery, but there is good evidence now that double level osteotomy is a very, very good option.
وفي سؤال مهم قوي من الدكتور ماهر وانا كنت مستني اسمعه من حد من الزملاء بصراحه: is there are problems with total knee replacement after osteotomy؟ ده سؤال مهم قوي فعلا.
سؤال مهم جدا. It depends what osteotomy was done.
Yes.
Okay, so again, I've done knee osteotomy fellowship. So my mentor had big numbers of osteotomies over the years. He's doing it like 100. He was doing 100 osteotomy every year. So I've done knee replacements on these patients, and it surprisingly it was very straightforward because the correction was not that big. So there is not a big deformity in the tibia. So MPTA is around 90, 94. So it's just like a completely normal knee replacement. The only thing to be aware of, because you've previously released the MCL when doing the osteotomy. So when you're doing the knee replacement, release the MCL, but very, very carefully, because it will be scarred, and then you release the MCL, release, and at some point it can completely snap. So that's the only worry. But so if it's a high tibial osteotomy, modern high tibial osteotomy, correction 55, Michelitz, it should be a straightforward knee. Just be aware when you're doing the medial release. If it was the old-fashioned osteotomy with a very big correction, you'll have a very deformed tibia, and the balance will be very difficult. So you need to think about your cuts, your soft tissue release. It will be a complex knee replacement.
لواء طبيب هشام العشري بعت بيج ثانكس والشكر لله سبحانه وتعالى يا فندم، ثم لاخواتنا واساتذتنا السبيكرز، ثم لحضرتك يا دكتور هشام
والله انا
بيه.
بشكر كل الحضور والناس المهتمه وبتسال، يعني بشكرهم جدا.
في two questions من اول سؤال من دكتور سيف الدين. maximum amount of correction before fracture hinge bone.
Hinge fracture is an important topic. So hinge fracture again, انا اي correction بعمله مش هيبقى very big correction. If you go with a very big opening wedge 14 millimeters for example, then logically your risk of hinge fracture goes higher. But I've almost never do a 14 millimeter wedge, because if I'm thinking of doing a 14 millimeter wedge, I'll be thinking double level osteotomy. But generally, for the hinge fracture, maybe we can go back and show this. This is another good thing to talk about. Okay, so this is my osteotomy line. What you need to do to avoid a hinge fracture, just make sure that this distance is 15 or 18 millimeters, 5 to 10 millimeters from the lateral cortex. And once you've done the osteotomy and you start opening up the osteotomy, this is where you really need to slow down. Okay? You put your osteotomes one after another. Take your time, because you're giving bone the time to have the plastic deformation. Okay, you don't rush with this step. Put one osteotome after another and give it like 30 seconds, 30 seconds, 30 seconds, and open it gradually. One important thing, we always think of the level of the osteotomy or the hinge at the tip of the fibula head, which is fine 99% of the cases, but sometimes you see the fibula head is going really, really close to the articular surface. In that case, you need to be aware that you don't go to the level of the fibula head. You really need to stay 15 millimeters from the joint, okay, and ignore the tip of the fibula head. So this is what you need to do to avoid a hinge fracture. Once you've got a hinge fracture, it depends on what type of hinge fracture. You've got a type 1 hinge fracture, which extends in the line of the osteotomy. If it's not displaced, you identified this intraoperatively, don't worry, finish your operation. I wouldn't change anything in my post-op rehab, okay? If you have a type 2 fracture line which goes distally, or a type 3 which is really bad and goes towards the articular surface, then if you identify this intraoperatively, you need to stop and then fix it. You can fix it with a lag screw, okay, from lateral to medial, or even put a small plate on the lateral side, because the type 2 and type 3 they are unstable. Type 1 I wouldn't worry.
Yes. دكتور ابراهيم مقار بيستاذن حضرتك في الايميل او الواتساب بتاع حضرتك يا فندم.
خلاص انا هدي لحضرتك الايميل، اللي عايز اي حد عايز يراسلني او يبعت حاجه على الايميل اديه لحضرتك طبعا.
شكرا يا فندم. We have finished questions. وتسمح لي حضرتك دكتور تامر بيه قبل ما نشفت للكيس برزنتيشن ان انا بفكر الزملاء الاعزاء الجمعه الجايه واللي بعدها ان شاء الله الحدث الكبير انترناشونال هيب وبينار. ان شاء الله باذن الله تعالى احنا معانا 80 سبيكرز من 9 دول. في 5 لايف ورك شوبس. في ورك شوب اول في الافتتاح يوم الجمعه الجايه الساعه 1:30 الظهر بعد صلاه الجمعه ان شاء الله. لايف ورك شوب من شركه ميرل من الهند على البرايمري توتال هيب ارثروبلاستي، ده لايف من الهند. معانا اكتر من 40 سبيكرز من مصر. الجمعه اللي بعدها ان شاء الله هيبقى الافتتاح الساعه 2 الظهر في لايف ورك شوب على البروكسيمال فيمورال فيكسيشنز اكسترنال فيكسيشنز دكتور جمال حسني. في لايف سيرجري من الهند على التوتال هيب ريبليسمنت. في الانديان سيشن 18 سبيكر من الهند. في اليو كي سيشن 10 سبيكرز من اليو كي. في معانا سبيكرز من ايرلند، في سبيكرز من بولند، في سبيكرز من جيرماني. في لايف ورك شوب من يو كي على الجمانيل الشورت واللونج. وفي لايف ورك شوب من كندا بروفيسور وليد قشطه على حضرتك الاوستيوتوميز اراوند ذا هيب. ان شاء الله يعني ربنا ييسر ويكون له فايده للزملاء الاعزاء ان شاء الله يا فندم. اتفضل يا
ما
فندم.
شاء الله حضرتك حاجة مثيرة للإعجاب، أنا ما سمعتش عن
العفو يا
أي
فندم،
ويبينارز
العفو يا فندم.
بهذه
ربنا
العظمة.
ربنا ينفعنا بيه
بجد
وينفع كل
والله،
الزملاء
ربنا
الاعزاء يا
يبارك
فندم.
لك ويجازيك خير على المجهود الرائع ده، حاجة
ربنا يبارك
جميلة.
في
أنا
حضرتك
أنا
دكتور تامر
يعني
بيه. ما
almost
هو لولا وجود
نفسي
حضراتكم
أحضر، بس
معانا
أنا ما بعملش هيبس للأسف.
لا الني جاي ان شاء الله، ما تقلقش يا فندم، الني جاي ان شاء
تمام.
الله.
كويس كويس.
ربنا يبارك في حضرتك يا فندم، جزاك الله كل خير يا فندم.
الله
اتفضل
يخليك.
سعادتك، نقدر نشفت بقى للكيس برزنتيشن ان شاء الله.
بالنسبة للcase presentations، أقدم case هينفع يبقى فيه interaction والّا بس أpresent وأقول
هم
نعمل؟
الزملاء الاعزاء بيكتبوا الانسر وانا بقولها لسعادتك ان شاء الله.
تمام. Okay. So first patient is 56 years old male presenting with right knee pain, previous history of medial meniscectomy. Clinically, there is not much apart from mild varus deformity and medial joint line tenderness. So if you can tell how would you think of this patient management, what would you do, investigations, what are the options? Of course, he's exhausted all non-operative treatment, he had painkillers, he had physiotherapy, he is struggling with his pain.
Yes, we can give just half a minute. الزملاء الاعزاء يكتبوا الانسرز. دكتور ابراهيم كاتب high tibial osteotomy.
It's definitely an option. Any investigations to check if he's a good candidate?
دكتور حسام new MRI and stitching film.
Yeah. Okay. Definitely.
دكتور
Yeah.
دكتور
So this is his long
Yeah.
leg view. This is the mechanical axis. So now we've got a long leg view. We think back again. We need to assess the deformity, severity of the deformity. So this is long leg view, line from the center of the femoral head to the center of the ankle joint. And this is the distance from the tip of the medial tibia plateau divided by the distance of the proximal tibia. And let's say this is 20%. So this patient has got a severe varus deformity, microliths of 20%. So potentially a candidate for osteotomy. His MRI scan showing moderate osteoarthritis. Other compartments, lateral compartment and patellofemoral compartments are normal. Going back to the X-ray, would anyone think of an arthroplasty, a full knee or a total knee or a partial knee replacement?
هو لو تسمح لنا بالاجابه بقى يا فندم
اتفضل طبعا.
في اليوني كومبارتمنتال ني ريبليسمنت. من اول حاجه في اليوني كومبارتمنتال ني ريبليسمنت that I have to have bone on bone. ده اول حاجه في اليوني.
تمام. Agree 100%. Any arthroplasty, bone on bone. Yeah. Moderate osteoarthritis is not an indication for arthroplasty. So this patient would not do very well with any type of arthroplasty.
Yes.
So we're thinking of an osteotomy. So he's got a severe varus deformity, and then we need to do what's the next step. So now we've got a varus deformity, microliths 20%. What would be the next step? Can we do high tibial osteotomy? Someone has raised his hand.
Yes. هو الدكتور متولي طبعا كاتب pay attention للميكانيكال اكسس of course. دكتور ابراهيم كاتب high tibial osteotomy medial opening wedge. there is varus proximal tibia of course. طبعا ده المين اوبشن. دكتور ثروت كاتب you have to have scanogram.
Scanogram is that the same as long leg views ولا ده حاجة مختلفة؟
لا السكانوجرام عشان نشوف الانجلز
لا you don't need a scanogram.
Yeah.
السكانوجرام انا ما اعرفش السكانوجرام في مصر ده بيتعمل مع السي تي صح؟
yeah.
مع السي تي
مع الاكس راي كمان بتعمل روتين ليه يا فندم؟
بس بيبقى ويت بيرنج ولا لا؟ هو ده السؤال. ويت بيرنج خلاص يبقى هو هيسيرف نفس البيربس طبعا. بس you don't need someone to do or measure the angles for you. هو الأحسن إن أنت to measure the angles yourself لأن أنت اللي هتعمل ال pre-op plan. أنت عايز X-ray حتى لو هو measured the angles. You can't rely on a radiologist or a radiographer أو فني. Don't rely on anyone. This is your operation. You need to have a pre-op plan and execute the plan. So you get a long leg view or a scanogram, yes, fine, but don't rely on anyone giving you the measurements, okay?
Yeah.
So next step would be doing a deformity analysis, measure the angles, and we have got these angles. So this is the MLDFA 87, which is within normal, and then MPTA is 81. So MPTA of 81, his Miclet is 18%, then this is a candidate for a high tibial osteotomy, okay? I'll show some. This is my pre-op planning, exactly the same. Miniature technique, mechanical axis, new mechanical axis, hinge point, line to the mechanical axis, another line to the mechanical axis, and then copy exactly the same alpha angle. And this is a close-up. So again, this is the wedge. You need, again, measuring this wedge, make sure this is calibrated. My X-rays are calibrated. So if I'm measuring 9 millimeters or 10 millimeters, it is 10 millimeters in reality. If there is a magnification, you need to account for the magnification. So pre-op plan, 10 millimeters, we add 1 millimeter for the thickness of the saw blade. So I need 11 millimeter opening wedge.
Yes. دكتور ابراهيم بيدي كومنت يا فندم ان السكانوجرام is a CT survey non-weight bearing.
But it's not useful. And non-weight bearing is very different. The mechanical axis is with the patient weight bearing. So the planning will be very different. And you'll be surprised how much difference you'll get for weight bearing versus non-weight bearing.
والدكتور اسامه برضو بيسال حضرتك على التو ليفل، الحاله دي كانت للتو ليفل osteotomy.
No, he doesn't need a two-level osteotomy because his mechanical axis is passing through the medial compartment. And now his MPTA is 81. I think I've got my alpha angle was 7. So that's 7. So my correction will be 7 degrees. If I add 7 degrees to 81, that's 88. So I'm still within the good limits of MPTA. If I'm doing a correction, if my planning showed that my alpha angle is 15 degrees, yeah, and then my MPTA post-op will be 96, then that's too much. Then we think about double level osteotomy. But generally speaking, rough idea, in a patient where I'm start thinking of double level osteotomy is a patient where I draw the mechanical axis and it's running outside the knee. I know this is a severe deformity, and then you can start thinking about double level osteotomy. So this is intra-op. Again here, this is a ruler. So what I'm doing here, if I go to my pre-op plan, this line is measuring 40 millimeters from the joint line. And then intraoperatively, I get a ruler and make sure I'm 40 millimeters from the joint line. Because if I start my osteotomy here, my pre-op plan is gone. It's completely different. So I make sure I'm starting in the same point, 40 millimeters from the joint line. This is my first K-wire. I use only 1 K-wire, not 2 for the osteotomy. So I go with my K-wire. This is the level of the fibular head. I go all the way. The hinge point should be somewhere here. So I go all the way to the lateral cortex, but my saw blade will stop at the hinge point, okay? So I've done the osteotomy. This is a metal wedge to open up my osteotomy. Again, this step should be done very, very slowly. Be patient. You don't want to get a hinge fracture. And this is the final image with the plate gap. There is no bone graft. I didn't use bone graft for this one. And this is his post-op X-ray. I think this was 3 months, so there is some callus, not fully united. And this patient actually is recovering well, but is complaining of pain on the medial side related to the plate. So I'm waiting for him to be fully united, and then I will remove the plate, which is a very common procedure. 50% of the time. Some surgeons in Germany, I think they just remove it routinely, which is not wrong, but it's another operation. Any questions about
عندنا ثلاثة
this?
questions على الحالة دي يا فندم. أول question من الدكتور حسام. We do high tibial osteotomy without fracture the hinge up to 16 millimeter. Is it right?
Well, I can't tell if you're doing the osteotomy without a hinge fracture, 16 millimeters, that's fine. But the question is, how is your MPTA post-op? Because with the big correction, you might end up with an oblique joint line, which again makes outcome maybe is not as good because of the shearing forces. And when you go back and try to do any replacement, it might be a problem. But it's not I avoid big corrections just to avoid a hinge fracture. No, you can probably do it. And then one more thing, you might not see a hinge fracture on the X-ray, but I think there are a couple of studies which show that there might be a hinge fracture that you can't see on X-ray. So with the CT, the incidence of hinge fracture is much higher than we think. But as long as it's type 1 hinge fracture, yeah, that's fine.
وده فعلا الكومنت اللي حضرتك تفضلت وقلته يا دكتور تامر بيه، هو السؤال بتاع اخونا الدكتور عماد. If you do double osteotomy the result is oblique joint line.
No, it's not. هو قصده ان لو عملت double level osteotomy result is ده هيؤدي الاوبليك joint line.
Most probably.
I don't think so, because with a double level osteotomy, if I'm not changing the MPTA and MLDFA higher than 94 MPTA, for example, then I shouldn't be ending up with a high with an oblique joint line. And there are many papers. I can send you these papers and have a look. It's bigger surgery, more complex, comes with more complications. But the trend now with big corrections, double level osteotomy is the answer. I can send you a number of papers.
Yes. في two questions من حد من الزملاء الحضور، هو مش كاتب اسمه. You don't use protective key wires with high tibial osteotomy?
I don't normally do. You can. Yeah, it's not a bad idea, but I don't normally do, because alhamdulillah, I don't get many hinge fractures in the proximal tibia. But it's definitely an option. Some osteotomy surgeons use it routinely.
نفس الزميل العزيز هو سائل سؤال تاني. Do you use kickstand screw principle in Tommy-Fex plate?
What screw? Does he mean the golden screw?
لا انا ما اعرفش بصراحه السكرو برنسبل. كيك ستاند سكرو برنسبل.
I don't know what is kickstand
I don't have an idea about that.
يمكن هو قصده على جولدن سكرو. هو في التوموفيكس بليت تحط البروكسيمال سكروز، وبعد كده في جولدن سكرو. هو كورتيكال سكرو عادي، بتستخدمه ان انت بتكمبرس البليت، بيكمبرس البليت للبون ديستالي، بيبقى في نفس الهول دي، بيكمبرس البليت للسكروز. السكرو ده بيبقى دايركتد شويه ديستالي in this direction. الفانكشن بتاعته ان هو بيكمبرس البليت to the bone and compresses your hinge. Once you put all the screws, you remove the golden screw and then replace it with a locking screw. So this is I do use this if that's what he meant.
Yes. معانا سؤالين من اخونا دكتور ابراهيم نور. Do you put the plate directly on bone proximally or over the periosteum and medial soft tissue?
Put it over all the soft tissue. I don't strip the periosteum or try to do it under the MCL. Just do my osteotomy and put the plate. It's a locking plate, so it should be fine sitting on all the soft tissues. And I don't cut the hamstrings. I just release a little bit with the MCL release.
السؤال الثاني برضو من دكتور ابراهيم. And how the plate affect the MCL healing if put directly on bone?
It doesn't affect it doesn't affect the MCL healing, and actually MCL laxity is almost never an issue with these patients.
Yes. Another question, if the head fibula at high level with joint line, it's necessary to do osteotomy of the fibula or not?
No, you don't need to do a fibula osteotomy. I've never had to do this with a medial opening wedge high tibial osteotomy.
تمام. في سؤال من دكتور حمدي وحضرتك already mentioned it, bone graft, using bone grafts and how much degree of correction. يعني حضرتك already have mentioned it يا فندم. دكتور سؤال من دكتور محمود, you don't do biplane osteotomy for all cases?
I do biplane osteotomy for every case. I don't do any single plane osteotomies because it's much more stable. It gives you more surface area for healing, and this is how I've learned osteotomy. So there's no reason for me to do a single plane osteotomy.
سؤال من الدكتور إبراهيم مقار, in plantification before surgery, you can connect the hinge point with the old one and the new mechanical axis, where you choose the point in the new mechanical axis.
Okay. احنا مثلا في pre-op planning, I draw my normal mechanical axis which would be somewhere here. Okay. And what I need to do is draw another line from the femoral head with the new mechanical axis. The way I choose my new mechanical axis is by calculating. So let's say this is 100 millimeters, yeah? Okay. So I want to go Micklitz 55%. So 50 will be neutral, yeah, neutral axis, neutral mechanical axis. I want it to be 55%. So which means if this width is 100 millimeters, I want this to be 55 millimeters. Okay, and this usually goes through the slope, lateral slope of the medial tibial eminence. So during my planning, I don't draw a random line just passing anywhere. So I have to measure the length of the proximal tibia, okay, and then figure out what is 55% of the proximal tibia, and then go through the 55% and then draw my line from the center of the femoral head where it should be 55%.
Another question from Dr. Hussam, the difference between Tomifex and Podoplate.
Tomifex is a much stronger plate. It's a locking plate. I've used Podoplate before, but this is much stronger. It's almost the standard now for a high tibial osteotomy. There are some other new plates like New Clip. I haven't used them, but I wouldn't use the Podoplate. If it's available, if it's the only option available, I would use it definitely. It's not a problem. But I would be more careful with my rehab because this plate is not as strong. So don't go weight bearing, fully weight bearing early. With these plates, I go fully weight bearing or weight bearing accelerate after 2 weeks. If I've got only a Podoplate, I will go touch weight bearing or non-weight bearing for 6 weeks. And the thing is, you can't, if you've got something that works well for you, that's fine. But don't copy one operation and use a different implant, for example. You can't copy, if someone using a Tomifex, weight bearing accelerated, you can't do this with a Podoplate for a different reason. It's a different plate, a different principle. Even with the other locking plates, New Clip, I've had colleagues who've had broken plates. It's a very new, very modern, very expensive plate, but I've had colleagues who had broken plates after an osteotomy. So if you're transitioning, you have to be very careful.
Yes. Another question is from Dr. Gamal Qasim, is post-operative severe pain candidate for plate removal?
Yes, any patient who's got significant persistent pain after surgery is definitely a candidate for plate removal. And as I said, 50% of these patients have pain just because of the plate. You remove the plate, pain is completely gone.
Yes, sir. Another question from Dr. Yaqub, indication of infratuberosity osteotomy.
So I don't do any single plain osteotomies. There's no point for me. This is more stable. The only time where I would go infratubercle is doing a reverse plain osteotomy, as discussed, the our colleague who asked about the patella baja. If there is patella baja, I'll do a biplanar, but I go down the redirect my second limb of my osteotomy distally.
Yes. Another question من Dr. Ibrahim. In plantification of high tibial osteotomy, where you choose the point in the new mechanical axis for calculation of the alpha angle.
So this is what we've mentioned last time. So if this is my new mechanical axis, I said if this is 50%, I'm aiming to 55%. So I measure the width and then divide this by 55, figure out what is 55%, and get my new mechanical axis to pass through this 55%. If you want to make it simple, you can choose to go through the lateral tibial eminence.
Well, last question, I think حضرتك already جاوبته من دكتور عماد. Any situation to do lateral closing wedge osteotomy in high tibial osteotomy? Already حضرتك
It's an option. I haven't done a lateral closing wedge. Medial opening wedge, it is safer. It does exactly the same job with a good outcome. So this is what I'm trained to do. So I'll just stick to medial opening wedge.
We have finished questions, Dr. Tamer B. في another case حضرتك؟ Okay, thank you so much.
This is quick one. 62 years old male. He had presented to clinic. He had a left high tibial osteotomy 2017. Very happy with his osteotomy. He is a builder. So he's got no concerns about the left knee. He's presenting with right knee pain, medial compartment osteoarthritis, examination, mild varus deformity, tender on the medial joint line, nothing significant in his clinical exam. Ligaments are stable. He's not a smoker, no medical problems. He's 62, works as a builder. So the question is about management.
Yes, yeah. Questions about the management and your comments. The first comment from Dr. Hassan, physiotherapy and medical treatment.
Yes, definitely. Here we don't get patients referred to see a surgeon unless they've done all this. So patients are referred only for surgical treatment. So he's had physiotherapy, he's had everything. Yes, injections, he had injections, actually multiple injections, steroid injections, by the way, not hyaluronic acid. And then by time, the effect of injections started to fade.
Yes. Dr. Abdullah is asking about MRI, lateral view.
Well, yes, you can get an MRI to check other compartments. Yes, definitely.
Dr. Sarwat is saying high tibial osteotomy. Of course, it's an option.
Okay, so to go a bit further with the discussion. So this guy, I said, okay, you're happy with the high tibial osteotomy on the left side. Do you want to have, and he looks like a good candidate for high tibial osteotomy on the right, active, physical job, he's a builder, no medical history. So I asked him, do you want to have an osteotomy on the right side? And he said, I'm not sure. He said he is about to retire in 2 years. He's a builder, but he's about to retire in 2 years. So what would you do then? Would you give him still an osteotomy, say this is the only option? Would you do an arthroplasty, and why? What's the problem if he's retiring in 2 years?
Yes. هو طبعا هو في العديد من الزملاء بيتكلموا على الباي بلين اوستيوتومي، وفي بيسالوا على اللونج فيلم وتو ميجر ذا انجلز لونج فيلم ويت بيرنج. دكتور ابراهيم النور،
ايه السؤال عن اللونج فيلم؟
هم بيقولوا يعني we need long film عشان to assess.
لازم long leg standing والpatella has to be in the center.
Yeah.
Any rotation will change all your measurements.
Yes.
هما اللونج leg views انا ما شفتهاش قبل كده عليها، اللي شفت في مصر السكانوجرام، وهنا مش في كل الاماكن عندهم او عندهم الايكويبمنتس، بس في اماكن ما بيعرفوش يعملوها، لان برضه في اماكن ما بتعملش اوستيوتومي اصلا. فكان مثلا لما اروح مكان جديد بروح بتوع الاكس راي، اقول لهم انتوا عندكم بتقدروا تعملوا لونج لاج فيوز؟ يقولوا لي طب هنسال سينيور تكنيشن، وبعد كده بتضح ان عندهم الايكويبمنت بس ما بيعرفوش يعملوها، لان هو بياخد اكس راي على الهيب، اكس راي على الني، اكس راي على الانكل، وبعد كده بيحتاج يستitch الاكس رايز. فالموضوع محتاج ديسكشن مع المكان اللي بيعمل الاكس راي، بس it has to be weight bearing.
We have no more comments, Dr.
Okay,
Tamer.
تمام. So this patient, he looks like is a very good candidate for high tibial osteotomy. I said high tibial osteotomy. He said, I'm retiring in 2 years. I had 12 months out of work. Sorry. I had 12 months out of work when I had this osteotomy, which means I will have 1 year out of my 2 years left off work, which is not a good option for me. So what I've done is I'm putting him on the list for a medial unicompartmental knee replacement. And one thing to bear in mind, when he had his osteotomy, he was 55. Now he's 62, so he's closer to having medial compartment osteoarthritis. His situation now is a bit different. He doesn't want to go through a 12-month recovery period. He just said, okay, I'll have a medial compartmental knee replacement. So I've arranged an MRI scan and put him on the list for a medial uni. One complex case. So this is a 21 years old male. He had an injury as a child to his left knee. He had a proximal tibial fracture, treated conservatively. Now he presented with a instability. So his problem is his knee gives way when walking. Let's have some comments.
Waiting for comments. This case especially مش عامل MRI يا فندم؟
عامل MRI، عامل كل حاجه عشان cut it short. يعني هو عامل MRI there is no arthritis, no ligament injury, PCL is intact, ACL is intact, long leg views, no coronal malalignment. He had even a rotational CT, no malrotational deformity. Everything else apart from these X-rays, everything else is fine. Clinically, he hyperextends on the left side compared to the right. He hyperextends by 15 to 20 degrees. So first question, what's the abnormality here on the lateral view?
Dr. Ahmed is writing posterior closing wedge osteotomy.
Okay, it isn't theoretically, but how can you do a posterior closing wedge? How can you get to the back of the knee, take this wedge?
Yes.
How can you do that? I think it's impossible. Any other options? There is an easier option.
Dr. Ziad is asking to correct tibial sloping.
Yes, definitely. So this patient has got a reverse proximal tibial slope. So slope is normally 3 to 7 degrees in this direction. This is the reverse slope. So this is 10, 15 degrees reverse slope. And that's why he's got hyperextension. He gets this instability when walking because of this reverse slope. So otherwise, all the ligaments are fine. So what we planned is doing an slope changing osteotomy. And this would be an anterior opening wedge high tibial osteotomy.
في حد من الزملاء كاتب حضرتك tibial slope is in reverse, so high tibial osteotomy with correction of the slope.
Yeah, but what height? Yes, but this is not going to be a medial to lateral. It's not a medial opening wedge. It has to be an anterior opening wedge tibial osteotomy. And there are different ways of doing this. One common way is to do a tibial tuberosity osteotomy. Okay, long tibial tuberosity osteotomy. Lift the tibial tuberosity. Make an osteotomy anterior to posterior. So you've taken this wedge, taken the tibial tuberosity, and then do an osteotomy heading towards the PCL, open wedge, correct the slope, and then put the tibial tuberosity back. Okay, so the tibial tuberosity will act like a biological plate, and then you put some screws and fix your osteotomy with a plate. That's an option. But here in this case, we felt that this proximal aspect will be a bit too short, and it was intraoperatively. So the other option is, this is a complex osteotomy. We've got an option here to get a 3D model, get a CT scan, 3D model of the whole lower limb, measure all the angles using CT, and then plan 3D printed jigs for the osteotomy, 3D printed plate, which is too fancy. You can do all this without the 3D planning and printing, but it's available, so why not? So this is what I've done for him. So this is intraoperative. This is the tibial tuberosity fragment. So done first a tibial tuberosity osteotomy. We've lifted this up, okay? And then this wire is just to get an idea of the joint line. This is parallel to the joint line, and this wire is for the osteotomy. So I will be going with my saw blade distal to this wire. And this wire was a transverse wire from lateral to medial as a hinge wire, but it didn't work. The 3D jig was supposed to be to have a hole for this wire to be going through the hinge, but this wasn't accurate, so we've left it, but it didn't do the job. And then now I've done the osteotomy using my saw blade, just distal to this wire. This is post osteotomy, and this is the radiolucent Homan or retractor that we're talking about. So this Homan was always somewhere here when you're doing the osteotomy. And then now opening the osteotomy very slowly, you have to take your time in this step. Now it's almost neutral, the slope. And now we've got this fancy 3D printed plate. So this plate is designed to fit exactly on the femur. And I've put two bone graft wedges. So this is one wedge, and I think this gap was, the opening wedge was really big, around 20 millimeters. And this is a final view with the plate. We've put the screws. So now we've got the tibial tuberosity. So this is my tibial tuberosity fragment. I've put the tibial tuberosity back, and then use the tibial tuberosity fixation. So 3 screws for the tibial tuberosity. In other situations, you can just fix your osteotomy with tibial tuberosity screws as a biological plate if it goes proximal enough. But here, this fragment was too small, so it was a very good thing that I had this plate ready. So I've used the plate, and then because I couldn't put any screws proximally, but then just to have better sleep, I've put these extra 2 staples for fixation. So these are the final images: lateral view, slope corrected, not 100% normal, but that's almost neutral. But we couldn't open this wedge anymore. 20 millimeters is just the maximum you can do here, and this is the final AP view.
Excellent.
Any questions about this?
هو في suggestions من الزملاء الأعزاء، بس هو حضرتك already يعني مشكورًا يعني شرحت الway of management. We can go with the next case, sir.
Next case هي really ما كانتش في البرزنتيشن ده، هي مش osteotomy بس we can discuss it if you like.
Yes, yes, sir, of course.
This patient is a 62 years old male patient. He had an injury to his left knee 6 months before presenting. He had a complete quadriceps tendon tear. I think it was missed initially. He was somewhere in the south in Devon or Plymouth, initially missed. And then anyway, he presented to me after more than 6 months. With this MRI, there's a big gap, 5 centimeters or 4 centimeters gap. He's got weakness in his left knee, 30 degrees of extension lag weakness. He's not walking properly, really struggling. So what are the options?
هو كل الكومنتس اللي معانا على اللاست كيس، فاحنا مستنيين اي كومنتس على النيو كيس يا فندم.
ماشي تمام.
يس. دكتور ثروت عيد كاتب كوادريسبس ريبير.
Repair if it's a new injury. That's the challenge with this case. If this is a fresh injury, yes, definitely a quadriceps repair. If this is the quadriceps tendon, what I would do is 2 Krakow stitches. Okay, another Krakow stitch. So we've got 4 limbs, and then in the patella, what I do is drill 3 tunnels. You can use anchors if you like. I don't trust anchors. So I'll drill 3 tunnels into the patella, longitudinal from proximal to distal, pass these threads, and then tie them distally. But this will work if this is a fresh injury. With this gap, just a simple repair is not going to work. You need to do a reconstruction or augment your repair with something.
هو ده فعلا الكومنتس اللي مكتوبه بعد كده دكتور تامر بيه. دكتور مصطفى ودكتور مصطفى كاتب على السيمي تندينوزس جرافت.
تمام.
وكذلك واحد من الزملاء الاعزاء هو اسمه مش مكتوب كاتب برضه ريكونستراكشن باي تندون جرافت.
تمام صح.
دكتور حسام والدكتور زياد كاتبين على الري انسيرشن وذ زد بلاستي كوادريسبس بلاستي كوادريسبس لانثنينج.
Quadriceps lengthening, it's fine, but it will not give you enough length. So here I think you should be prepared. Options: do a direct repair, definitely. In full extension, you probably can pull with some release, quadriceps release the soft tissues. You can get the quadriceps tendon distally enough to do a repair. Sometimes you might end up with a gap. But the problem is you can get it in full extension, but in flexion, when the patient starts flexing, it will be very difficult, and you probably the repair will fail. So need to be prepared with few options. So one option is to use some synthetic tapes. We've got something called new ligament, and there was a Lars ligament. I don't use this artificial. This particular patient was diabetic, so I wasn't very keen on using any foreign material. I've got a few colleagues. So by the way, all these cases, okay, none of the complex cases that I've discussed, it's not the case. I see the patient in clinic, take him to theater. Doesn't work. So any complex case is discussed in our MDT meeting. So we've got 4 surgeons. We've got a meeting every 2 weeks, online, simple. Anyone can do it. Zoom meeting. It's a Teams meeting. Every 2 weeks, we get our complex cases. Even if there is any doubt, what do you think about this? Is that reasonable? So we get all these cases presented on Teams online. We don't have to meet. Present. What do you think? What shall we do? So in our meeting, they said, okay, you can use the last ligament, which is an artificial ligament. I wasn't very keen because this patient was diabetic. So I said, okay, I'll have the last ligament or a new ligament available, but my plan A will be a semitendinosus because it's more biological, it's autograft, etc. So intraoperatively, open up the knee, just do lots of release, quadriceps release, and then I managed to get the quadriceps tendon distally, did my normal primary repair, 3 tunnels, 2 Krakow stitches. Important, what stitch to use. If you're using ethibond, it has to be number 5, okay? If you've got fiber wire, number 2 should be fine. I've seen surgeons using number 2 ethibond, which is not strong enough. So if it's ethibond, number 5. It's fiber wire, it's number 2. Fiber wire is much stronger. So I've done my normal repair, and I've taken the semitendinosus, and what I've done is I've drilled a transverse tunnel in the patella and passed the semitendinosus through the patella, and then weaved it through the quadriceps tendon as an augmentation. Okay. The only difficulty here is having too many tunnels in the patella, which is a bit worrying. So what I've done is do my transverse tunnel in the patella and keep the reamer there, yeah, to protect this tunnel, and then do my 3 longitudinal tunnels so I don't cross with the tunnels. Okay. And initially, when I started doing these patients, I was very worried they will get stiff, they will not be very happy, but surprisingly, they do very well and they are very grateful actually. So this is one of them. So this is, I think this was 3 months after surgery. He's got full extension, active extension, no lag. And I tell them in clinic, see, this operation will give you some strength with the cost of losing movement. This is very important for these patients to know. So this was more than 90, which was fine. Let's see if this video works. Yeah, it's working. Okay, I think that's it. Any questions, any comments?
هو في comments كتير على الحالة، ويعني هي طبعًا it's a wonderful case بصراحة يا دكتور تامر بيه، يعني حالة بصراحة رائعة.
والله هو السيرجري دي ما فيهاش حاجة technical. يعني هي repair عادي بس augmentation بسيمي tendinosis. هي السربرايز ان they do طبعا post op hinge knee brace. I leave them in extension for at least 3 to 4 weeks and then 30 degrees increase 30 degrees by 2 weeks. بس هي surgically هي ما فيهاش أي special talent الصراحة.
بس هو طبعًا هو يعني intensive course of physiotherapy post operative عشان يوصل للrange ده يا فندم.
Definitely.
هو
Without
في
physiotherapy, you will
yes.
have a very stiff knee and you will not be very happy.
يس. وفي سؤال كان عجبني من أخونا دكتور مجدي أندراوس على الحالة اللي فاتت يا فندم، اللي هي عاملة high tibial osteotomy على الleft side والother side كان بنتكلم على الhigh tibial osteotomy. فبيقول إن إزاي إن هو العيان satisfied بالhigh tibial osteotomy على الleft side بالرغم من الsevere arthritis اللي في الmedial compartment. هو فعلًا أنا لاحظت إن في severe arthritis في الmedial compartment.
البيشنت فعلا انا البيشنت ده انا شفته الاسبوع اللي فات او الاسبوع ده كمان.
تمام.
يعني لسه فاكره كويس قوي. البيشنت جاي ريفيرد عشان الرايت ني. اللفت ني اتس نوت ا نورمال ني. قلت له انت هابي باللفت ني؟ قال لي اتس اوكي. يعني هي مش 100% pain free بس هي مش عامله له مشكله في شغله، بيقدر يشتغل بيها عادي. اللي بيوقفه في شغله الرايت ني. فده يقول لك how powerful is the osteotomy. This is bone on bone. Just because you've offloaded the medial compartment, the osteotomy works well. وفي اكتر من كده. هنا في during الكوفيد بالذات اخر سنه كان عندنا ديلي جامد قوي بسبب الكوفيد. فانا كنت بشوف كتير patients بقالهم waiting 2 years. خلاص. الميديال compartment osteoarthritis particularly I've seen a number of patients اللي هم referred بعد سنتين، وبعد كده هو جاي العياده بيقول لي انا مش عارف ومش متاكد انا هنا ليه. فبقول له واكس راي شبه بتاع الاوستيوتومي ده. بقول له انت هنا ده ني كلينيك. يقول لي يقول لي انا كنت ريفيرد زمان بس هو عنده arthritis bone on bone. يقول لي بس انا دلوقتي كويس. قلت له خلاص أنا مش هعمل لك حاجه. عيان بون اون بون osteoarthritis لا عمل فيزيوثيرابي ولا عمل اي حاجه. with functioning well عنده شويه بين بياخد باراسيتامول كده every now and then. مش هعمل له ولا osteotomy ولا arthroplasty. Remember we don't treat the x-rays, we treat the patients.
بالضبط. كنت لسه عايز أقول الcomment ده بقى يا فندم، ده اللي كنت عايز أقوله. إن إحنا الdecision making بتاعنا ده مش radiological، it's a clinical and radiological. موضوع الأشعاعات اللي بتتبعت على الواتس وإيه الdecision الكلام ده طبعًا nonsense. يعني ما فيش حاجة اسمها decision. يعني أنا لو شُفت سعادتك الحالة اللي حضرتك عرضتها والعيان اللي non symptomatizing ده مع الsevere arthritis اللي في الmedial compartment definitely إن أنا ده يا unicompartmental يا total knee. إنما العيان is not symptomatized يعني فبالتالي ما فيش حاجة اسمها radiological decision.
تمام. واكتر من كده كمان ان في ساعات البيشنت بيبقى جاي expecting operation.
Yes.
الاوبريشنز اللي احنا بنعملها اغلبها عشان تعالج البين. تمام. والاوبريشنز بتاعتنا are not benign operations سواء arthroplasty. في عوامل كتير متداخله حد عايز يوبريت او بس generally لو حد قريبك او بتاع لو عنده arthritis بس ما عندوش pain جامد مش هيعمل surgery. فانا بقول للعيان الاكس راي your x-ray is bad enough to justify a knee replacement. Okay, but we do knee replacement to relieve pain. How much pain you've got. تمام. I can't feel your pain. البين ده حاجة subjectives. أنا ما أقدرش، ما عنديش جهاز أقيس بيه البين بتاعه. فأنا أقول له والله أنت البين بتاعك قد إيه؟ 9 out of 10. طيب بتاخد pain killers؟ باخد ترامادول 3 مرات في اليوم، مش قادر أمشي، بمشي 100 yards. أوكي خلاص. لكن واحد تاني هيجي يقول لك لا والله أنا عندي bad days و good days، باخد paracetamol every now and then. طب عندك مشكلة في المشي؟ لا أنا بمشي عادي. طب في مثلا واحد يقول لك إيه؟ ما عنديش مشكلة في المشي خالص وعنده arthritis x-ray is bad، بس مثلا I can't play golf. Okay, again you have to be careful. Okay, this patient has got no problems in normal walking, right? He can't play golf. He gets a knee replacement. If it works well he'll be able to play golf. بس الsuccess rate بتاع knee replacements أنا بتكلم في ال Western world and UK is 80 to 90%, which means في chance 10 to 20% الناس دي هيبقى عندها pain. في ناس عندها severe pain، في mild pain etc. بس the success rate is not 98 or 95. 80% success means pain relief. فالبيشنت اللي هو بيقدر يمشي بس ما يقدرش يلعب جولف، لو الدنيا مشيت هيبقى مبسوط ويقدر يلعب جولف. لو هو طلع واحد من ال 10 او 20% دول وبقى عنده مشكله في المشي العادي it's a problem. فانا بحاول بس بشبهها البيشنت. مثلا البيشنت لو هو ازازه مليانه 70% او مثلا ازازه 20%، اوكي، knee arthritis, a knee replacement can get him مثلا to 80%, he'll be happy. لكن هو لو 70 وعايز ال 10% دول، لو العمليه مشيت كويس اوكي، لو مشيتش كويس هيبقى هو خسر كتير. يعني قول لهم you've got a lot to lose.
I think we have no more questions. هي كلها suggestions للمانجمنت من الزملاء الأعزاء. هو في زميل عزيز، هو مش كاتب اسمه، كاتب ان مستر اندرسون ويلسون published a paper in EGA committee that high tibial osteotomy done in cases up to 80 years despite of tricompartmental osteoarthritis, just correction of mechanical axis give better result. ايه الكومنت بتاع سعادتك على دي يا فندم؟
Tricompartmental.
Tricompartmental.
I haven't seen this paper and I don't know who's Elson. There is one Elson in Newcastle بس ما اعتقدش. لو الايج اوكي ماشي، انا osteotomies فيه 75 ممكن 80 extreme cases، بس tricompartmental arthritis is not an indication for high tibial osteotomy. I would never do that.
هو النقطه اللي انا عايز ادسكاس مع حضرتك بقى دكتور تامر بيه، ان هو حضرتك عارف في اليوني كومبارتمنتال كان من ضمن الكونترا انديكيشنز لو في باتيلو فيمورال جريد 3 او 4، وبعدين دلوقتي بدا يعني يوسعوا شويه في الايرا بتاع اليوني كومبارتمنتال، وبدات تبقى دي مور فليكسبل. فهل الباتيلو فيمورال ارثرايتس بالنسبه للهاي تيبيال اوستيوتومي اتس ا بيج بروبلم؟
It's not an absolute contraindication، بس again هي الموضوع الجادجمنت it's the whole picture. فلو patient عنده medial compartment osteoarthritis خلاص، ومودريت او حتى moderate to severe patellofemoral arthritis بس هو 60 or 55 خلاص arthroplasty. اوكي، لان هو already is not very young etc etc. بس لو عيان تاني مثلا 35، انا ساعات بشوف عيانين عندهم arthritis وهم 35 او 40، 35 او 40 وعنده medial compartment osteoarthritis established والpatellofemoral joint فيها a little bit mild to moderate osteoarthritis. In this case, yes, it's not a contraindication, but this patient needs to understand this operation might buy him few years before having an arthroplasty, but he might continue to have some pain related to the patellofemoral joint. لأن الأوبشن الثاني لحد عنده 40 أو 35 arthroplasty is really not a good option. والاسكا كونسنسس ده فيه كلام جميل جدا جدا. كل الحاجات دي معموله سؤال وجواب بالevidence. كل حاجه obesity, smoking, patellofemoral joint, it's a great consensus and it's free, it's available to anyone.
Yes. اعتقد we have no more questions. هي كلها comments على في question من الدكتور علي هاشم. Suturing the tendon is in extension or inflection knee? I think about the quadriceps deficiency case.
In extension, you can't put the sutures in flexion. You'll struggle. You can't. اللي بيحصل ان ال quadriceps tendon be retract, okay, and then it's very difficult to get it in flexion. You have to get it in, even حتى في ال fresh cases بتعملها في extension, and what I do is do my repair in full extension and then test my repair 50 degrees, 70 degrees. It depends how strong my sutures. If I start to see a gap, then I stop. بس لو fresh case 50 to 70, if there is no gapping, then I'm happy. بس في these cases, it's definitely in extension, and I will not start extension before weeks. I have to have some healing and then go gradual flexion.
Yes. هو في سؤال مهم من اخونا الدكتور زياد يا فندم. هو بيسأل على السلوب تشينجينج osteotomy case. Would you just fix the tuberosity back in the same place or would you distalize it? ده سؤال مهم بصراحة. Would
Very
the
nice
surgery
question.
affect patellar ligament length?
Very, very nice question.
Yes.
You'll not be able to fix the tibial tuberosity in the same place. لأن أنت دلوقتي what happens is you've opened this wedge, okay, and what happened, you've lengthened the tibia, so you've lengthened. So if this is 20 millimeters, then the bed for the tibial tuberosity is shorter by 20 millimeters. So what you end up doing is putting the tibial tuberosity where it should be, yeah, but distally, I haven't got a picture distally here, but distally you'll have a gap. Sorry, let me put this. So if you've done a 20 millimeters opening wedge distally, you'll have a gap, so the tibial tuberosity will end somewhere here, and then you'll have a gap where there is no bone. Because the bed now is longer, so you match it proximally, not distally.
It's a very important point, sir. I think we have no more questions. All suggestions for the one of our attendees is asking about, our dear colleagues asking about post-operative peering. I think you have already mentioned it, sir.
No.
I think we don't have no more questions, Dr. Tamer B.
تمام.
هو طبعا يعني لا هو لا لا ألف شكر لحضرتك يا دكتور تامر.
ربنا يخليك يا رب.
مش يعني الشكر لله سبحانه وتعالى ثم لحضرتك على المحاضرة الرائعة دي. يعني هي دي من أجمل المحاضرات اللي أنا بصراحة يعني من 4 سنين بدير الكورس، من أجمل المحاضرات اللي أنا سمعتها، واللي هي فعلا concentrating على البراكتيكال points. يعني it's not an academic lecture. هي it's a very well made presentation بصراحة. فأنا بشكر حضرتك جزيلا.
ربنا يخلي حضرتك، ده بس من ذوقك، وأنا والله اتشرفت جدا
لا يا فندم
بمعرفة حضرتك بعيدا عن أي شيء يعني.
ربنا يبارك في حضرتك.
مبسوط جدا إن أنا كنت موجود معاك في الويبينار النهارده، والناس اللي حضرت، ويا رب يكون استفادوا
وأنا
حاجة.
سعيد جدا بالأسئلة. يعني الدسكشن فعلا يا فندم هي اللي بتسري التوبيك الموجود فعلا. يعني very good discussion، وزملاء أعزاء أفاضل يعني كانوا موجودين معانا. بنشكر حضرتك شكر جزيل 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 يا دكتور تامر بيه.
ربنا يخليك يا رب، وانا متشكر جدا لحضرتك وكل الناس اللي حضرت، ونشوفكم على خير ان شاء الله في حاجات تانية
كل خير.
الله.
متشكرين جدا، ونشوف حضراتكم على خير ان شاء الله الجمعه الجايه بقى في الانترناشونال هيب ويبينار. النيو ويبينار جاي، ما تقلقش يا دكتور تامر. شكرا يا فندم. كل عام وحضرتك بخير. شكرا يا فندم. عليكم السلام ورحمه الله وبركاته. تصبحوا على الف خير يا فندم.